Yeah, he joined our club lately, and we are all working at the same target, same group. So I will present some cases in the acute coronary syndrome. This is ischemia club that everybody had heard of it, that we every other Wednesday we meet. Usually started and ended with Professor Abdullah Shahab. We have always a very good discussion, and I am proud that all my friends are very expert. Who is the high risk STEMI? Maybe comorbidities, high thrombotic risk, bleeding tendency, elderly, renal, previous MI, previous CABG, high risk anatomy, cardiac shock. And those are the very well known risk criteria for non-STEMI, who is now the shifted from high risk to very high risk, and high risk criteria. Until we reach the definition of protective PCI, if there is a lot of comorbidities, there is complex anatomy, I mean left main, very complex left bifurcation, CTO in the setting of acute coronary syndrome where it is the reason, and depressed ejection fraction or hemodynamic embarrassment. And these are the how to define the complex PCI or complexity of the regions, maybe the same what I mentioned before, heavy calcified, CTO, impaired LV function, all these things. So those are some of the patients I saw in the past few months. This is a patient in the Heart Institute. They transferred him to the emergency room. Still in Egypt, they come to the emergency room. They don't go to the cath lab immediately. And then the moment they just started the angio, he had VTAC. And so luckily enough, he was there. If this VTAC happened while he was in the elevator in the lift, maybe he could have died doing resuscitation there. So this implicates the importance of time. Of course, the mechanical protocol is not difficult, but having the patient on table in time. This is another patient, he's 70, acute anterior, acute non-STEMI, acute coronary syndrome non-STEMI, and he is presenting with hypotension and passing into acute pulmonary edema, and he had 3-vessel total occlusion. And so how come that he was living with these arteries? Then we thought that something happened today, and the only artery that is suspected was the LAD. And so let's pass a wire quickly in any branch we reach. And then we started to see a ghost of the LAD. And then we started to open that. And then we started to have blood pressure. We didn't have even time to bring the intra-aortic balloon or something. Then we stented the LAD. And we optimized the result. The patient improved. And then we decided to do other lesions, but the patient felt in a good condition. He didn't like us to continue in the subsequent sessions to open the CTO of the RCA or even the CX. Ejection fraction improved and is still alive. This is a 90 years old patient diagnosed with pneumonia. And then I saw his ECG. I told him this is acute pulmonary edema. It's not pneumonia. It happens maybe in all patients. A typical presentation. He had no chest pain. ECG was left bundle. So we decided that is acute anterior. Ejection fraction is 20, and so let's do the intervention in the shortest time we can do. And so we put him on table. We didn't need to artificial ventilation in 92 years old patient, but we were able to do this procedure in minutes, and he improved. This had been done 5 months ago. Ejection fraction almost 40% and still surviving. He's doing well. We were in one of the ischemia club, and then our colleague from France, he said, I have a case of acute coronary syndrome, inferior MI, would you excuse me? And then after 1 hour, he sent me this one. And he said, Dr. Ahmed, believe it or not, he had acute inferior MI, but actually it was aortic dissection. And so sometimes, the lesson from that sometimes acute MI is dissection. It could be something else. It could be massive pulmonary embolism. So don't only concentrate on coronaries. He had, of course, this patient had been operated. This is a patient, he had been referred for surgery. This is another problem because of this left main trifurcation. And then he disappeared for a few months and he came back, chest pain, but the surgery was not done for logistic things or because he's not happy to do surgery or whatever. And so we decided it is a simple, we will do provisional. And if we need something in the branches, maybe you can do drug balloon like my friend Abdullah is doing. So this angio was done after 2 months. He was coming electively. He had no more events, but it was a total left main. So what was the decision? To talk with the surgeons who did not already do the operation when he was less risky, or what to do? Let's try trying to pass a wire and to see what happens. Maybe this is a soft lesion that occluded the 90% distal left main occlusion. And so wiring was not that easy, but the patient was stable. We had intra-aortic balloon in place, and we were ready for any complications. And then we starting with, who will tell me that we need to wire also the circumflex or something, but with total occlusion, at least you should have wire in the main artery, and then you decide what happens. We started now to see a ghost of the LAD. It was thrombotic. So sometimes the clinical situation is not reflecting what happened in the arteries, but be ready for anything to happen with left main. It was thrombotic, but we did not need to do aspiration of the thrombus. When we were in a better situation, we wired the circumflex, and then we stented the LAD from the left main. We did POT, and then we started to work on the circumflex. So now we are in a better condition, and we started to, and our aim was to put a drug balloon in the ostium of the circumflex. However, there was little dissection, and the flow was not that good, and so we turned that into just a tap technique. And so we put a balloon and a stent, and we finalized with POT after the kissing. And this was the picture after we did everything. Although we did a drug balloon, but after the drug balloon we discovered this kind of dissection, and so we shifted our protocol or our pathway. This is a 37 years old. He is a heavy smoker. He had tap technique 2 years ago somewhere, and he came with non-STEMI, acute severe chest pain. Now the circumflex is totally occluded, restenosis in the circumflex, and he had 99 occlusion of the LAD, and he was in this acute situation. And so we opened the LAD. We thought, should we just open and then we talk to the surgeons or what? We opened, and there was a little thrombus in the LAD, and then we stented the LED and wiring the diagonal. However, it went provisional. We didn't need to do anything for diagonal, just POT for the proximal part of the LED to optimize. And this was the final picture. And he did well. He continued like this for several months, maybe from February until 2 months ago. And then he came to tell me that, Dr. Ahmed, I observed that in the last week I started to have again chest pain on mild effort, and told him, now you will have surgery, because if we have restenosis in the stents, we will not do something, we cannot do anything. So let's do angio now and talk to the surgeon. So I did the angio. The right coronary was giving collaterals to the end of the LED. And then we discovered that, yes, there is subtotal occlusion, but in the stent that was 3 years ago, not in the stent that we put 6 months ago. And so again, we discussed with him, we can have surgery? He said, no, Dr. Ahmed, I don't feel all right. I don't need surgery. I will prefer. And so we opened the artery. You can imagine that the CX is still occluded, and we were trying to, but it was small. And so passing the wire and stent, yet it was high risk. It's like a ship case, or we should have this patient on ECMO, but the situation was in the cath lab